Everyone, and welcome to today's Hopkins Hour online seminar. I know some people are still joining us, so I'm just going to slowly start us off here for today. Today's seminar is titled Navigating the Fog, the Fatigue Experience and Management After Traumatic Brain Injury. We would like to extend a warm welcome to all Hopkins Centre members, partners and collaborators who are joining us today. Before we begin today's presentations, I would like to acknowledge the traditional custodians of the unceded lands on which we are all meeting from today. For me, I'm sitting in Meanjin on the lands of the Turrbal and Yagara people, and I would like to pay my respects to the elders past and present, and to all Aboriginal and Torres Strait Islanders peoples who are meeting us here today. For those of you who don't know me, my name's Louise Gustafson, and I am one of the research leaders, leader of Program 2 at the Hopkins Centre. The program that I lead is called Enabling Technologies and Environments, but I also have other research experiences. So we've pulled together a seminar today about another area of research that we have been conducting. So I'm here as chair today for today's online seminar. And I'm really pleased to present for you today. We're going to have two presentations and then a panel discussion with our presenters where you'll have an opportunity to ask questions and for us to talk about the topic of the fatigue experience following traumatic brain injury. Just some quick housekeeping before we get moving. We're aware that the internet can be a little bit troublesome sometimes and connections might drop in or out. But if you experience difficulties, the normal applies. Sometimes just pop out of the room and back in again and see if that helps. But also feel free, if something's not quite right and you're able to access it, to pop a chat in the toolbar and one of our team might be able to help you out. Certainly, if you're having, you should know that there's no problem with you. If you need to, you can leave this Teams platform and then rejoin at any time using the same link. And for those of you with a hearing impairment, we're using closed captioning. It's available via the top level toolbar on your Teams platform. We really encourage you to pose your questions as they pop into your minds throughout the day, throughout the presentations today. So you can do this by either typing your question into the chat box. So there's a link up above your screen. It looks like a little kind of conversational thing. You can pop a chat in there. And certainly they will be pushed forward to me and I will present those to the team at the end of the presentation when we're having the discussions and the Q&A. We'll do our best to answer and address as many as your points, but certainly if we can't, we will respond to others after the event. If typing into the chat box is not available to you, then please feel free when we get to that point of the presentation, to the discussion point, to raise your virtual hand to just let us know that you want to ask a question, and I will identify that and ask you to take yourself off mute and you can then ask your question that way. So I'm really pleased today to introduce you to our speakers. So we have Caitlin Spalding, first of all, who is joining us for the first presentation. Caitlin is an occupational therapist who is now working full-time at Griffith University and has quite a significant clinical experience working in the neurological rehabilitation space. We're also joined by our clinical partners from Metro South and PA Hospital. So we have Janelle Griffin from Occupational Therapy and Rebecca Sini from Occupational Therapy. And Emily Gibson will be joining us. We're very grateful for our clinician partners who are running 2 Hopkins hours today from their commitments within their clinical positions. So to kick things off, I would like to hand over to Caitlin, who's going to present to us a scoping review that has been conducted. Over to you, Caitlin.
Lovely, thanks, Louise. So hi everyone, as I said, Louise said, my name's Caitlin, and on behalf of Louise, I'd like to present our research, which was exploring a multidisciplinary approach to fatigue in post-traumatic brain injury using the International Classification of Function framework. And this work was supported by a seed grant through the Hopkins Centre. So traumatic brain injury is a worldwide contributor to death and disability, with 69 million individuals estimated to experience a TBI each year. A common symptom is post-traumatic fatigue, and this disabling and distressing symptom impacts participation and quality of life for many individuals. As such, it's of great interest to researchers and clinicians to understand best practice approaches for managing post-traumatic fatigue. Current literature has begun to explore effective fatigue interventions in the TBI population. Researchers found that post-traumatic fatigue is multifaceted, it's multimodal in its clinical treatment approaches, including sustainable levels of exercise, judicious medication prescription, and behavioural therapy provided by multidisciplinary rehab teams. But because of the variability in study methodologies, including primary interventional outcome measures, the way to implement such complex treatment approaches isn't clear. Researchers have had a great difficulty in defining and assessing fatigue, despite it being a very common symptom across neurological disorders. So fatigue may be the result of physiological factors such as disease or nervous system injury, or exacerbated by psychological factors such as disease or nervous system injury, or exacerbated by psychological factors such as stress, pain, or sleep disturbances. So it gives us researchers and clinicians pause to consider these factors when choosing and implementing fatigue interventions. So the use of health frameworks, such as the International Classification of Functioning, Disability and Health, known as the ICF, can help researchers provide this structure to enable comparison of research results. So the ICF is widely used as a conceptual basis for definition and measurement and health policy formulations. And for example, researchers have used the ICF to investigate the depth and breadth of burns outcome measures, as well as developing rehabilitation management plans. So exploring post-traumatic fatigue management through an ICF lens, we feel would support an enhanced understanding of the phenomena and how to incorporate multifaceted interventions to address various levels of functioning and disability. So the objective of this study was to profile and map the available evidence for fatigue management used for the TBI population onto the ICF framework. This review was conducted using a recognised framework. 5 research questions were developed, and exploring types of fatigue reported, how it's measured, interventions reported, if it addresses specific types of fatigue, who delivers them, and reported outcomes for fatigue, as well as how all these measurements and interventions and outcomes are mapped onto the ICF framework. So in February 2022, we looked at several databases using MESH and keywords and terms seen on the slide here. Studies of quantitative, qualitative, and mixed methodologies were reviewed. Papers were included if they described post-traumatic fatigue as an outcome measure, if fatigue was the focus of the intervention. The population we were interested in were adults aged 18 years or older, and included any percentage of individuals with a TBI. To capture the aspects of a multidisciplinary approach, we allowed for the inclusion of any clinical setting, so inpatient, outpatient, or community-based, any discipline, and format of intervention. Reasons for exclusion were if the journal article was a literature review, not published in English, or perhaps had a paediatric population included. We used the Confidence Program for a systematic approach with a double-blind full text review completed. Data was charted, analysed and collated in a table format, looking at those research questions, and a qualitative content analysis was completed to complement the objective of this study, which was really considering and mapping this evidence to the ICF framework. We looked at ICF linking rules as described by Cieza and colleagues, and that was used as that foundation to help us develop that content analysis. From an initial search strategy yielding 2,020 articles, 258 met preliminary inclusion criteria, with 81 articles undergoing a full text review. 32 were excluded as they didn't meet eligibility, and 49 articles met the criteria for inclusion. Of the included articles, 27 reported results from randomized control trials, 15 were observational designs, with 3 of these including qualitative data, 3 were case reports, and 4 were conference abstracts. So in answering the first research question, defining and measuring fatigue, only 15 of the 49 articles provided a clear definition. Mental fatigue employed descriptions of cognitive symptoms such as irritability, poor concentration. Physical fatigue focused on impacts of excessive energy consumption, resulting in physical symptoms such as headaches and kind of physical tiredness. Over 20 different fatigue outcome measures were used. The fatigue severity scale and the mental fatigue scale were the most common. To address the second and third research questions, there were a variety of fatigue management interventions reported, mainly addressing either mental or physical fatigue. Majority was pharmacological, followed by articles describing complementary and alternative interventions such as light therapy, multifaceted psychosocial education groups focusing on symptom control and behaviour change. There were also activity-based interventions, mainly aerobic exercise and a headset game. There were psychological interventions such as CBT and mindfulness-based stress reduction group classes. Interventions mainly occurred in the community or outpatient settings, with only 3 articles describing an inpatient hospital intervention. So despite a variety of interventional modalities, all articles reported a singular discipline approach. For the fourth research question, positive outcomes were seen in RCTs of pharmacological interventions, as well as psychological interventions of CBT and mindfulness-based stress reduction group classes, as well as activity-based interventions as well. Education groups and complementary and alternative interventions demonstrated a variety in outcomes depending on methodology, with mixed and inconclusive results. So finally, next slide, thanks Hannah. To explore that fifth and final research question, we looked at content analysis in relation to the ICF framework. So body function was the most common ICF component focus of fatigue outcome measures in the reviewed studies. There was a strong focus on mental function or cardiovascular capacity required for enduring physical exertion. 3 measures did look at activity and participation, specifically determining one's ability to carry out daily routine under the impact of fatigue, and another 3 looked at personal factors such as experiences. For fatigue interventions, again, body function was the most popular ICF component seen in 45 of the 49 articles. These were interventions that explored specific mental function categories or performance component categories, such as attention, executive functions, orientation, and emotions. Activities and participation were a focus for interventions that had that more educational and practical component, and for example, where one had to explore new concepts, solve problems, as well as kind of carrying out new daily routines. Interestingly, no interventions appeared to focus on personal categories. Environmental factors of assistive technology and natural and man-made changes to the environment were a focus for some of the light therapy interventions, but no studies explored a focus on relationships or support aspects of fatigue treatment. All fatigue outcomes reported in the reviewed studies, again, aligned with that body function ICF component. There was a strong focus on reporting change in cognitive and emotional functional categories, including energy and drive and sleep and motivation. And less than half of the outcomes reported explored activities or participation, and none of them reviewed a return to work or complex occupational tasks, nor social environmental factors such as that impact on relationships. So, next slide, thanks, Hannah. The importance of a multidisciplinary approach to brain injury rehab is well documented. However, no interventions for post-TBI fatigue in this review were found to use that multidisciplinary approach. This silo style impacts the ability to conceptualize the use of more than one approach at one time. Other complex chronic disease management approaches, such as pain, have introduced multidisciplinary clinics to enable this integrated care. This review found that fatigue management interventions with a strong bias towards addressing fatigue at a body function level only, with less than half exploring activities and participation abilities. And as I said before, none addressing social or environmental aspects of the individual. This contrasts with that growing evidence for fatigue management, that it should be multifaceted and it should address very different aspects of the individual in order to achieve best outcomes. And finally, it was evident in this review that there was that disparity in the intent of fatigue interventions and then actual outcome measures used. And we know that using meaningful assessments is crucial to demonstrating clinical effectiveness and assisting translating research evidence into practice. So in conclusion, this scoping review has used the ICF framework to conceptualize post-TBI fatigue management. And while positive results focusing on body functions has been reported from those silo-styled interventions, further opportunities to develop multimodal approaches that target other health and function components, including activities and participation, environment and personal factors, may enable a greater impact on fatigue management. The next slide just shows a QR code to the publication of this study in the Brain Impairment Journal last month. And there's also some references here on the next slide. Any information, any questions, reach out. I'd now like to hand over to our clinicians, Beck, Emily and Janelle, for their presentation. Thank you.
Thanks, Caitlin, for the introduction, and thank you, Louise, for the invitation to present today. My name is Rebecca, and I have with me Janelle and Emily, and we're presenting today on behalf of our research team, which includes ourselves, Professor Louise Gustafsson, Dr. Ryan Bell, and our consumer partner, Mr. Robin Franklin. So we have a multidisciplinary team approach to identifying the question that we've got today, and we currently have a research project which we'll explore further today. So we'll include an overview of the project thus far and some of our findings from our data analysis, which helps to tell the fatigue story and the lived experience for our patients with TBI. The research team is currently preparing a paper for publication, which will be able to outline the full results and a more in-depth of our discussion findings. So for some background, traumatic brain injury, or TBI, is defined as an alteration in brain function or other evidence of brain pathology caused by an external force, and it's among the most serious and disabling neurological disorders in all of society. Fatigue is one of the most prevalent and debilitating complaints following TBI, which is irrespective of injury severity. Estimates of the incidence of post-traumatic brain injury fatigue varies from anywhere between 16 to 80%, which is a huge disparity of estimation. Fatigue itself is broadly defined as the awareness of a decreased capacity for physical and/or mental activity due to an imbalance in the availability, utilization, and/or restoration of resources needed to perform activity. The term fatigue is recognised as a multidimensional construct, which can be delineated into 3 categories. So, physiological fatigue refers to the state of general tiredness due to physical or mental exertion that can generally be ameliorated with rest. This encompasses both physical and cognitive fatigue. Psychological fatigue refers to a state of weariness with reduced motivation, prolonged mental activity, or boredom. And finally, pathological fatigue refers to a state of tiredness not linked with previous exertion levels and is not ameliorated by rest. And the literature describes this as the experience of fatigue for people who have sustained a TBI. So research has found evidence for the impact of fatigue on daily functioning in relation to household, family, social, and recreational activities. However, this is typically reported in the context of reduced satisfaction and quality of participation rather than the frequency of the quantity of participation. Qualitative research has captured the impact of fatigue on daily functioning and socialisation. For example, the increased effort required for daily tasks was described as bicycling into an invisible wind. It is widely acknowledged that an TBI and its effects have broad impacts not only for the individual, but their family and friends who do provide informal support.
So the clinical background to the project stemmed from clinicians working the Brain Injury Rehabilitation Day Hospital, noticing that patients with traumatic brain injury were frequently reporting a persistent tiredness and overall failing to resume engagement in their previous activities of daily living. The patients were physically tired and/or mentally tired with limited physical and mental endurance for their tasks, and often it was observed that they struggled to complete multiple day hospital therapy sessions. Coincidentally, a conversation occurred with Robin Franklin, who at the time was a Princess Alexandra Hospital volunteer, as well as a past patient of the unit, and highlighted his fatigue experiences and mapped ongoing issues for both himself and his wife in managing his fatigue post his traumatic brain injury. We also noticed an impact on carers or families with actual or perceived shifts in responsibilities due to the fatigue experienced by the person with the traumatic brain injury. In general, it was noted there was a lack of carer awareness about post-TBI fatigue and how to manage it. And this prompted the clinical team to formulate a team of clinicians, researchers, and Mr. Franklin as a consumer to generate a number of research questions. So the current study aimed to better understand the experiences of people with post-traumatic brain injury fatigue and their support needs, including the secondary impact on their carers. The key research questions were, firstly, what is the nature and trajectory of fatigue severity in the first 2 years following a traumatic brain injury? And the second question was, how is fatigue experienced by people with traumatic brain injury and their carers? The study's design is a mixed method concurrent exploratory approach. Longitudinal quantitative data was collected along with qualitative data from both patients and their carers. Eligibility for the study included, firstly, participants who attended an outpatient appointment at the Brain Injury Review Clinic, people who had sustained a moderate to severe traumatic brain injury within the last 2 years. The person had a carer or a caregiver involved in supporting their recovery. They were aged at least 18 years of age and they were able to provide informed consent. Similarly, to be eligible for study participation, caregivers needed to be at least 18 of age. Oh, I said that. I'm talking to myself again. Patients who described significant fatigue experiences to their treating occupational therapist and who met the outlined eligibility criteria were approached by a member of the research team who outlined the research study to the person and their caregiver and offered participation in the study. Once a patient had consented to the study, 2 objective fatigue measures were completed at time point 1, which refers to their initial outpatient review appointment. Participants who completed their measures were seen between 3 and 6 months later when they attended the brain injury rehab outpatient clinic again, and the objective fatigue measures were repeated at that time. 2 fatigue scales were completed at time 1 and time 2 to measure fatigue impact. These scales are the Fatigue Scale for Motor and Cognitive Function, or the FSMC, and the Global Fatigue Index, or the GFI. Participants who were identified as having significant post-TBI fatigue, defined as scoring 43 or higher on the fatigue scale for motor and cognitive functions, were offered participation in a qualitative, semi-structured interview to further explore the lived experiences of fatigue. We do therefore need to acknowledge the potential for a bias within the qualitative data, given participants were only recruited if they experienced very significant fatigue.
Descriptive analyses were used to report participant demographics and reported fatigue at the 2 data collection points. Non-parametric analyses explored the trajectory of fatigue for the total sample between the 2 data points and differences between the TBI survivor and caregiver data. Qualitative data from semi-structured interviews were analysed by applying the interpretive descriptive approach described by Thorne in 2008. As prior knowledge of the fatigue post-TBI is limited, particularly for the carer group, an inductive approach to data was taken. Coding of the data was completed by a member of the research team, and codes were synthesized to generate patterns and relationships from the data before the final themes were presented. The quantitative and qualitative data were analysed separately, but brought together in the final section of the results, which we'll cover shortly. In total, 30 participants, 15 people with TBI and 15 caregivers were consented to the study. However, 1 person with TBI was 25 months post-injury at the first data collection point, and therefore they and their caregiver were excluded from the study. Of the remaining 14 people with TBI, there were 6 people less than 6 months post-TBI, 4 people 6 to 11 months post-injury, and 4 who were between 12 and 18 months post-injury. Participants were predominantly male and had a median age of 38 years. 7 participants identified significant fatigue impact on the objective fatigue scale and consented to participate in the qualitative interviews with their caregiver. We will outline some of the early quantitative data results. On the first formal fatigue measure, the fatigue scale for motor and cognitive functions, 78% of the participants reported moderate to severe levels of fatigue at the first time point. 64% of the participants continued to report moderate to severe levels of fatigue after 3 months. Overall, there was no significant change for total or cognitive fatigue between P1 and time 2, but it was nearing significance for physical fatigue. The FSMC demonstrates that fatigue experiences for participants who are 12 months or greater post-TBI remain static, with more variable change observed for those less than 6 months post-TBI, for those 6 people, across total, cognitive and physical scores. With regards to the global fatigue index, 57% of the participants exceeded the total score threshold for abnormal fatigue at the first data collection point, and this increased to 64%, at the second data collection point 3 months later. This change wasn't significant. In contrast, 86% of the 14 caregivers exceeded the threshold for abnormal fatigue at the first data collection point, compared with only 57% of those that had sustained a TBI. There was then a statistically significant reduction to 57% of caregivers who exceeded total score threshold for abnormal fatigue at the second data collection point. There were significant reductions in the reported GFI severity, distress, and impact on ADLs.
With consideration and mindful of the agenda today, we won't have time to outline the qualitative data, but the study has gathered rich examples of the lived experience for people with TBI and their caregivers, which has enhanced the findings outlined in the quantitative data analysis. As an overview, following data analysis, the following themes were identified. Firstly, brain injury or fatigue, triggers and predictability, routine and planning, roles, responsibilities, and relationships. And these will be comprehensively discussed in the full paper.
So the combined findings of the quantitative and qualitative data may suggest that the fatigue experience for people following a TBI stabilises after the 12-month recovery period, with changes or fluctuations most likely to be reported during the 6 to 12-month period of recovery. The qualitative data describes how the person with TBI and their caregiver are learning to identify triggers or when to expect fatigue to occur during the early recovery period. And they're also developing routines or strategies that reduce the impact of the fatigue experience on a day-to-day basis for that particular person. This does potentially involve more active input from the caregiver during those early stages and early transition home, including the adapting of usual roles and responsibilities to accommodate different structure or breaks for the person experiencing fatigue, which may be reflective of the high fatigue experience described by caregivers. However, the caregiver then appears to adopt a more monitoring role over time. This change, coupled with the settling into a new routine of the new roles and responsibilities, may equally explain the decrease in the fatigue experience for caregivers over time. The raw data across the 3 recovery time periods highlight the individualised nature of the fatigue experience, with people reporting variable patterns of timing, severity, and impact. Despite the apparent equitable impact of cognitive and physical fatigue on the FSMC, descriptions linked to cognitive fatigue were more commonly described by both the participants with TBI and their caregiver in the interviews. Finally, only a few individuals identified a significant impact of fatigue on their everyday activities on the GFI. However, the qualitative findings suggest that the development of the daily routines around everyday activities is vital, and this may have impacted the scoring here, and we hypothesize that the findings might have not actually accurately represented the experience of people living with fatigue. For example, people might have already adapted their routine at home already so that they are conducting activities earlier in the day, for example, to limit the impact of fatigue, or they have changed how they complete the activities so that fatigue is less likely to occur. In summary, the data analysis has presented valuable findings to us, which support the observation of clinicians and the reports for people with TBI and their caregivers. Fatigue is multifactorial, individualised, persisting, and complex. However, we hope this information will help inform clinicians in how to assess fatigue, develop rehabilitation programs, and provide input around the timing and content of education. Notably, this study has presented new findings which highlight the high level of caregiver fatigue experienced by family members or caregivers, whereby a very high number of caregivers recognise their own fatigue, more so than the patients with TBI at time point 1. For caregivers, this fatigue experience has a marked improvement over time, which may be reflective of the high initial input required to help the person with TBI in the development of clear routine and daily structures to adjust to life with post-TBI fatigue. It is important to note that whereas caregiver fatigue was shown in this study to improve over time, the data showed us that for people with TBI, this fatigue experience was still present, if not worsened, a few months later. So it is worth noting that this also could be reflective of improved insight into what fatigue looks like for that person as well. So we envisage that clinicians will be better equipped to plan appropriate support and interventions along the trajectory of recovery, and better informed to provide relevant and timely education for both people with TBI and their families and caregivers around fatigue experiences and strategies for management. Thank you.
Great, thank you. Thank you to everyone for those great presentations. I can see that we've got some questions being posted in the chat, so we're moving to the Q&A section of the Hopkins Hour today. So please feel free to type your questions into the chat or raise your hand if you have any questions for the panel. I can see that there is one there already that I am going to pose to all of you, I think, and see who would like to answer. Christina, thank you, Christina, for posing this. Could it be assumed that the data and research might also correlate to the experience post-stroke? Or could some of those findings help support those impacted by an ABI more broadly?
Certainly finding. Christina, hi, thank you for that question. We can't assume that the data and the research correlates to ABI post-stroke, because obviously we collected the data from a TBI population, so we wouldn't want to assume that the findings and the outcomes would be the same across the populations. However, your second statement, some of the findings help support those impacted by an ABI. Yeah, absolutely. The findings, I think, are general, that they're going to get care fatigue, whether it's the ABI has been caused by a trauma or from a stroke or from another mechanism, but certainly where the person who has acquired the injury is suffering from a fatigue condition, then yes, very likely the carers will also feel the impact of that. So yes, the findings in that regard, I think, can be generalised across, but not the specific TBI findings for managing the same condition in stroke, no.
Great, thank you. I think, yeah, it just points to more work to be done. We love that when that gets generated from what we're presenting. I know certainly fatigue post-stroke has got a lot of, there's a lot of work happening in that space as well. The next question's for Caitlin here. From the scoping review, what should clinicians take away? What should they be thinking about based on the findings from the scoping review?
I think a couple of different things. For me, as a clinician in my past life as well, is that recognition that what we treat, we need to ensure we're evaluating and measuring appropriately to, justify and support any changes that we're seeing in support of that things are working well or they're not working well, and to best represent the experiences for people there. And I think also, again, depending on the nature of the profession that you're in. So for myself as an occupational therapist, I was surprised by how the lack of, connection to occupation and activity and participation that was seen in the research out there, and maybe goes to clinicians to consider when they're thinking about evidence and implementing evidence into practice, what's actually available, and that kind of connection to how we our own kind of principles as therapists as well, and to know that what is good is great, but also to consider then the gaps that are missing and how else we can best kind of support our patients there. I think it just highlighted also probably that we're doing a lot of work, but maybe it's not being reported on. I mean, obviously, since this scoping review's happened, Janelle and Beck and Emily have done their lovely paper and exploration on that, as well as those experiences. So more is needed there for clinicians and patients alike.
Great, thank you, Caitlin. Our next comment is from Stephen, and Stephen, I'd like to thank you for saying this. Before I mention what you've popped in the chat, we had hoped to have a lived experience expert on the panel with us today, but unfortunately that didn't happen. So we're really grateful for anyone's input, and Stephen, it's great to hear you say it describes precisely the fatigue impact for ABI that you experience. including the assumption that changes in management reduce impact and severity. It is really something I think that it would be very interesting for us to explore and understand further. Beck and Janelle and Emily, I don't know if you had anything that you wanted to add there. No? Okay, great. But yeah, thank you, Stephen, for that. We have, I'm assuming this is for our second presenter group there. From a guest, how did the findings align with what you see in practice? Were there any surprises in the findings of your study?
No.
Pleasantly no, because it was exactly what the patients were describing as their lived experience is what came through in the data, which I think as clinicians is what you hope to achieve through research, especially research project that was driven from reported experiences from our patients and their families and what they were then reporting to us. So in a really positive way, we feel like authentically for many years, people have been describing that they leave hospital and they expect that fatigue is just because they're not sleeping well in hospital and they're woken up at night and they have to share a room with other people and they're woken up for OBS. And when we get home, that will just get better. And what we see in our outpatient setting is that it doesn't get better. It's very persisting and people are really surprised by that. And also how much of a role it takes for the person and their caregiver to actively manage that and to really put in place strategies and changes and adapt their day-to-day to manage that fatigue long term. And I think what we've seen for a number of years and what hasn't been represented in the literature is the impact on caregivers, where people and their families would come in and they would say, we're so happy to have our family member at home, but we're also exhausted. And they're really not able to do all the things that they were doing before. So now I'm having to also mow the lawn and do all the cooking, and they can't drive, so I'm doing all of that as well. But there was really this change and this shift in the roles and the responsibilities. And we were hearing that the impact of the fatigue was not only on the patients with TBI, but also their families and their caregivers, and how that was changing the landscape for that family unit. And that was really reflected, more surprisingly than we thought, in the data, with the really high lived experience of fatigue for the caregivers initially.
I've also added to that what we did find as well, in practice as well as from the data, where at the follow-up appointment, the caregivers were reporting less significant impact of fatigue, and we put that down to what they're also reporting. They get into a better system, they get into the caregivers get into a routine, and they're better able to manage. So they yes, as Beck said, they've taken on more roles, more responsibilities, and initially it's overwhelming and it's quite a shock, but then they develop those strategies, get systems in place, get supports, put other practices in, and then they do not report their fatigue to be as significant down the track. Still present, but it takes on different forms, or they just have better ways of managing it.
Definitely. Thank you. I can see a quick question there from Kerry. Thank you, Kerry, saying worthwhile research. Was there any correlation between occupational status and experience of fatigue, such as if the participant had returned to work versus not working? I can probably take that quickly and let you know that very few, I think maybe one person had returned to working in the sample for that study. So that was something we couldn't explore, but certainly something that is worth investigating further. We know that some people invest all their energy in work and then are quite worn out for the rest of the day. I might just, if I can, quickly jump to, I think I can see Jenny Henson has popped her hand up in the air. I'm just wondering, Jenny, if you wanted to jump online and unmute yourself. We may need to, if we can. Thank you, Makala and Hannah. Hi, Jenny.
Hello, how are you?
Well, thank you.
I'm sorry I joined in late. I'm at the library and it took me a long time to join in. Has this been recorded?
It is being recorded, Jenny. Yes, it is. It will be made available up on the Hopkins Centre website.
Thank you.
Later on.
Also, the fatigue, you may have covered this already, but I'm 3.5 years in and it's still just debilitating.
Yes.
It sort of affects my life so profoundly. and I can't seem to strategize to avoid that happening. You probably covered strategies for that earlier.
Well, we might throw, I guess does anyone on the panel want to speak?
And the brain
quickly?
fog.
Yeah, the brain fog. Anyone on the panel want to just address quickly? I think it's still something we're trying to establish, Jenny, what's the best way to manage. And I think certainly in the study that was just presented, even though we only looked at people up to 2 years post their brain injury, I think you are talking to an experience that's shared by many of the fatigue having an ongoing and lasting effect.
Very much so.
Yes. Thank you for jumping online. We hope to some point have some strategies and some suggestions for you. There is a study that's coming that we'll talk about soon that might help to take some steps towards solving this for people. Thank you, Jenny.
Thank you so much.
I might jump back into the chat if I can. I can see there are lots of questions coming into the chat, and I know we probably won't be able to address them all, so apologies in advance for that. Jamie has popped there, fatigue is a significant issue for people post-TBI, impacting their ability to return to work and on everyday activities. So what is actually recommended in terms of practical treatment or further studies to better manage? Over to anyone on the panel to jump in about some practical strategies that you would suggest.
It's a great question.
Jamie, that's a common one that we see in our patients in the day hospital doing return to work programs. And essentially, we do a very graded program with the patient and their employer, looking at frequent breaks and reduced hours. That's the most common approach that we're taking. But in terms of a practical approach, and also in response to Jenny's statement before, we do a lot of education around pacing and looking prospectively in the week to determine what activities the person has, when they need to timetable or place that activity so that they know they're going to be at their optimum, recognising within themselves when their fatigue is the most significant, and then organising their activities and their schedule around that. So having that control of when they book themselves to do things and incorporating frequent rest breaks. That's in the day-to-day role in the ADLs. Then again, as I said, in the workplace, working with employers to incorporate elements of being able to sit at the desk or stand at the desk, having the breaks, working shorter hours, being flexible, allowing working from home. Those sorts of strategies have all been adopted by various employers to help support patients in return to work programs and managing that cycle of fatigue.
I might just add on that, we didn't ask specifically, this study wasn't looking at treatments or strategies. I think that could be a whole separate study itself. But what the qualitative data did show is that it's very individualised and multifactorial and persisting. So we kind of need to have a breadth of strategies up our sleeve to recommend, because the experience for each person and the impact for them on their life looks different. So we have to take that. I think our data reinforces that for future studies, that multidisciplinary and very holistic approach to strategies is really key to help this particular person manage this post-TBI fatigue, because despite you could describe it all as post-traumatic brain injury fatigue, but what that looks like for everybody on that spectrum or on that lived experience is so different. So we, as clinicians, find a lot of value in having a multidisciplinary team approach and a broad range of strategies that we can hope to apply more individually for somebody's particular context.
Definitely, thank you. And I think that speaks a little bit to the next comment and question from Marie, who's saying, to what degree do we think adjustment issues are important here versus, could we pick apart mental health interventions versus physiological interventions as strategies for fatigue, and how do we make decisions around that? And I think that's probably, Marie, what Beck's speaking to there. It's very individualised. It's probably where we're trying to get to. And I think, as Caitlin was talking about at the end of the review, it strikes us that, you know, the very multifaceted nature of fatigue lends itself to us to starting to view and approach it in a way that includes multiple possible interventions and strategies.
Yeah, I'll just add to that as a neuropsychologist. Also, yeah, I feel what I normally typically do with the patients is, you know, look at their experience of fatigue and looking at what factors could be contributed. And often it is, yeah, there might be some increased anxiety or stress that we know that can contribute to experience of fatigue, as well as, you know, low mood as well and low motivation and that sort of thing. So I make sure that we're looking at treatment for those things, as well as also the other, you know, pacing strategies, as well as, you know, we always obviously involve the doctors in terms of if there's other, you know, interventions that might support as well. So sometimes it's about looking at it all together and doing a bit of everything, really, to help.
And there's a great discussion going on in the chat here between Michelle and Angela. Michelle's asking any evidence or investigation for longer-term fatigue post-TBI, and perhaps separating it out from other possible causes, but certainly noting that 15 years on, Michelle is still struggling with constant fatigue. And Angela commenting that, you know, perhaps it hasn't diminished, but I've just learnt to manage it better. And I think, you know, all of these comments are really speaking to further work that needs to be done, and for us to be able to understand and help to, I guess, unravel some of the complexity for people here. Moving through, gosh, there's so much here. Thank you so much, everybody, for all of your comments and questions, and lots of things, I guess, that people are saying to help each other out. Thank you, Jenny, for sharing with us that, you know, 2 years post your spouse's ABI, the whole family actively participates in managing fatigue, and that if that fails, the whole family feels the impact for the day. That certainly speaks to what we were hearing. Christina sharing that you've built up your resilience to cope with your fatigue. So I continue to do it until I adapt, but it's not fun doing this, absolutely. I can very much appreciate that. Goodness me, there's a lot to keep up with here. Sorry, everyone, just mind with me while I'm reading through all of this fantastic chat. Lots of things around planning, routine and sleep, even a short sleep meditation session allowing you to reset. That was one of the very clear strategies that we heard. Caitlin, in the scoping review, was there any investigations into this idea of routines or resting or pacing that we were able to identify?
Certainly, positive results were seen in activity-based kind of interventions, ones where people were practicing and implementing those techniques, certainly ones that were perhaps guided, shameless plug, by occupational therapists, but doing that practical kind of approach, there was positive outcomes reported through there. Mixed results, positive, negative, for those more mindfulness-based kind of rehab techniques as well. So and really, to be honest, what I found disappointing in the literature was that the patient's experience really wasn't was greatly missing. Their voice and their needs were greatly missing, and as we can see, a lot of people have some very valid insights, not just to how they're experiencing, but what they kind of need then from services to support them in returning to what they need to do. And that is where I see a lot of good work kind of to be done, or what is needed anyway.
Definitely, thank you. There's a shout out to psychologists who helped me with compassion focused therapy also in the chat there. I can see there's lots of sharing of experiences there, which is fantastic. I might jump down. There is a question. that's about for person with a TBI. Back to you, Caitlin. I guess for the scoping review findings, I guess what's the important thing for people with TBI and for their carers to, I guess, know or think about or take away from that?
I think that we as clinicians need to, we're all often encouraged to base our treatment recommendations on what we see in the literature, but sometimes it can take a bit of time for that literature to catch up with what we need to be doing. And so I think it's important for participants and their loved ones to be continuing to voice their experiences, to be continuing to explore as we've talked about, multimodal, multifactorial elements of that fatigue, and how important it is to be exploring that individualized kind of approach with the therapist that they're involved in, because it's sounding like it's definitely a path forward that we need to investigate further, and that there's positives for there's positive outcomes for a range of different intervention kind of approaches, and we just need to get better as clinicians in listening to our participants and bring it all together in a concise way to make it more impactful for you.
Great, thank you, Caitlin. Kylie, I can see you've asked a question there. I'm very mindful of time, and I'm wondering that might take a little bit for us to answer. So if it's okay, we might take your question offline and get back in touch with you with some information there for you. I am aware that it's nearing the end of our time slot, so I would like to thank our presenters and our panel for their time today. We do want to just, I guess, raise awareness of a study that is underway here. It's a little bit of a shameless plug for those of us here at the Hopkins Centre. We're currently working with and about to start across June and July a series of co-design workshops where we are really interested in working with experts by experience. So people with traumatic brain injury who experience fatigue, plus their key support people, and expert clinicians who work with people with TBI from around Australia. Obviously, we have a specific number of people that we're hoping to recruit within those groups, and then we really want to sit and work with you all in a series of groups to really generate some ideas and potential solutions and think about what this program might look like. So drawing on everybody's expertise. So certainly get in touch if you are interested in being part of that. This has ethical approval through Griffith University. And yeah, certainly get in touch with me, or if you don't have time to get that email address down, get in touch with Hopkins Centre and they can connect you up with me. I can see that Michaela's shared information in the chat there about the recording that will be shortly available for everybody. So I would just like to take this opportunity now to thank everybody for attending. It's certainly been a very interactive and great Hopkins Hour today. We really appreciate you in joining us. I would also like to take the time to say thank you again to the presenters quite formally for taking time out of your busy days to share your research with all of us. If you would like to get in touch with any of the presenters, please do so. Contact the Hopkins Centre through the email address hopkinscentre@griffith.edu.au and connect with them to get in touch with any of the we can share the publication information with you for Caitlin, and certainly we are working on the publication for the second piece of work. We really look forward to presenting to you our next Hopkins Hour, which is coming up on June the 19th at the same time as today's events. And certainly keep your eyes out for emails. Our events team will be in touch and we'll send all that information out to you in the coming days and weeks. So thank you once again to everybody for your time and your attention today. I would like to wish you all the very best for your afternoon and say goodbye to you all. Thank you.